Hi, I'm Roy O. Dahil, a BS Public Health graduate of UP Visayas and currently taking Masters in Health Informatics. For this session in our class, including classification and terminology in medicine, I'm going to discuss with you the International Coding for Primary Care, or ICPC. But before we proceed, please download first the ICP summary sheet in the link provided in your screen. To facilitate discourse for this topic, I encourage everyone to continue our discussion online through YouTube or Twitter, or you may follow my Twitter account at @rdialdial_, or you can use these hashtags at the corner of the screen if you have any comments about my presentation. The International Classification of Primary Care, or ICPC, is the most widely used international classification for systematically capturing and ordering clinical information in primary care. The International Classification of Primary Care is compact, containing only 1,400 classes. However, it is comprehensive, covering multiple aspects of primary care, and is based on the epidemiology of primary care. Classes are developed based on frequency of occurrence in primary care, its public health importance, which is described as greater than 1 per 1,000 patients per year, the prognosis or outcome, and the value of interventions. Policymakers, funders, and providers of healthcare need to have information about the epidemiology of their communities, and they need to understand what is happening within primary care to improve health services. For providers to effectively record information about this as part of routine clinical practice, easy-to-use classification tools are necessary. ICPC was developed because policymakers, funders, and providers of healthcare need to have information about the epidemiology of their communities. They need to understand what is happening within primary care to improve health service. And thus, an easy-to-use classification tools are necessary for providers to effectively record information about this as part of routine clinical practice. ICPC is formally recognized by the World Health Organization's WHO Family of International Classification, or the WHO FIC, as a classification system for primary care. It is mapped to the International Classification of Diseases, or the ICD-10, which allowed communication between the two classification systems and the complementary usage of both classifications. Right now, ongoing cooperation between WONCA and the WHO FIC network exists for the revision of ICD-10 to ICD-11 and harmonization with the ICPC. In 1972, the Classification Committee of the World Organization of National Colleges, Academies, and Academic Association of General Practitioners or Family Doctors, also known as the WONCA, now World Organization of Family Doctors, first met in Melbourne and agreed that it was time to design a classification specifically for primary care. Many of its members had already been corresponding for years about morbidity classification for general practice. Recognizing the problems of the ICD and the need for an internationally recognized classification for general practice, the WONCA Classification Committee, now WONCA International Classification Committee, designed the International Classification of Health Problems in Primary Care, or the ICH-PPC, which was published in 1975. In 1978, adequate primary health care was recognized as the key to the goal of health for all by the year 2000. During the WHO Conference on Primary Health Care in Alma-Ata. The World Health Organization recognized that building appropriate primary care systems to allow assessment and implementation of healthcare priorities was only possible if the right information was available to healthcare planners. Classification of primary care data was seen as vital to this process. This led to the development of the concept of a family of classification within WHO, requiring new classification systems, particularly for primary care. The U.S. National Center for Health Statistics, or the NCHS, developed a classification of patients recent for visiting physicians. The NCHS supported the development of a new classification of reasons for encounter in primary care. A small working party was formed under WHO to develop the reason for visit classification. Over the years of work, the party developed the reason for encounter classification. Reasons for encounter, or the RFE, is the agreed statement of the reason why patient needs to enter the healthcare system. The RFE code focuses on data elements from the patient's perspective, making it patient-oriented rather than disease or provider-oriented. In 1979, the second edition of ICH-PPC was published related to the 9th revision of ICP. In 1980, the first field trial to test the completeness and reliability of the RFEC was piloted in the Netherlands. In 1983, the results obtained from the pilot study prompted further feasibility testing, which was carried out in 9 countries, including the Philippines, Australia, Brazil, Barbados, Hungary, Malaysia, Netherlands, Norway, and USA. Then, the same year, the third edition of ICH-PPC was published. In 1985, studies by a number of European countries was conducted to test the usefulness of the new classification systems in producing morbidity data from general practice for national health information systems. This involved translations of the classification and comparative studies across the countries. In 1987, in the course of feasibility testing, it was noted that RFEC could easily be diagnosed to classify simultaneously the RFE, process of care, and health problems diagnosed. RFEC evolved into International Classification of Primary Care, or the ICPC. The first version of the ICPC was published and is referred to as ICPC-1. In 1993, ICPC was revised and published in 1993 publication, The International Classification of Primary Care in the European Community, with a multi-language layer. 1998, Wonka published a revised version of ICPC, or the ICPC-2, with inclusion and exclusion criteria and mapping to the ICD-10. In 2000, a revised electronic version was released. This was referred to as ICPC-2-E, where E referred to a revised electronic version. In 2003, WHO recognized ICPC-2 as a WHO-related classification for the recording of data in primary care. ICPC is published in 19 languages, namely Catalan, Chinese, Croatian, Danish, Dutch, English, Finnish, French, German, Greek, Italian, Japanese, Norwegian, Portuguese, Romanian, Russian, Serbian, Slovenian, and Spanish. The International Classification of Primary Care, or the ICPC, broke new ground in the world classification when for the first time, the primary health care providers could classify using a single classification 3 important elements of the healthcare encounter: reasons for encounter, diagnosis of problems, and the process of care. Understanding the reason for encounters across a primary care population is essential for the development of people-centered health services. ICD was designed to allow healthcare providers to code a patient's health problem in the form of diagnoses. However, many symptoms and non-disease conditions that is present in primary care are difficult to code with the ICD, which in principle has been designed for mortality and morbidity statistics with a disease-based structure, and so diagnosis represents the healthcare provider a view on a patient's illness, which it may not necessarily be correct or appropriate. For example, weakness or tiredness in primary care does not result in a clearly classifiable disease. ICPC allows such data elements from the patient's perspective to be included. In doing so, it aims to be patient-oriented, at the same time being able to capture the provider's diagnosis and classify diseases which can be mapped to ICD when appropriate. Primary care is important because a large proportion of the world's medical care is provided by primary care. It has been expanding rapidly, particularly in developing countries. Primary care physicians manage a very wide spectrum of patients' problems: physical, psychological, social, and functional. Lastly, because good primary care is equal to good population health. ICD is designed to serve the needs of hospital care where the patients normally present a single episode of care and mostly with one often clearly differentiated problem. In primary care, however, healthcare providers deal typically with multiple episodes of care over time and deal with many often undifferentiated problems simultaneously. The benefit of ICPC is that it captures episode of care, or the EOC, over time. It does so by allowing the simple recording of the first contact between patient and healthcare provider concerning a certain health problem and ends with the last contact relating to the same problem. ICPC captures episode of care, or the EOC, which allows grouping of information over time. Healthcare providers can use this to improve continuity and coordination of care.
The ability to collect data using the episodes of care also creates more insight into the process related to certain conditions that reflect the content of primary care. The ICPC contains codes that are mainly based on the frequencies with which they are encountered in primary care and with a level of detail that is appropriate for primary care. It is then possible to tailor ICPC to match local epidemiological needs. Consider this, for example, the patient visited a doctor because she is feeling tired, to which the doctor diagnosed her as fatigue and requested for further tests, say complete blood count. The patient returned bringing her test results and asked the doctor for the diagnosis. The doctor diagnosed her with iron deficiency anemia. After finding out that the patient is diagnosed with IDA, the doctor further ordered colonoscopy. On her third encounter, the patient returned with the results of the colonoscopy and gave it to the doctor. The doctor diagnosed her with a cancer of the colon and referred her to the other hospital. So in this example, with ICD coding, only the fatigue, IDA, and cancer of the colon will be captured and documented. The RFE and the process are not coded. But in primary care, these two elements are important. This is where ICPC is beneficial. ICPC allows coding of the reasons for encounter and the management done by the doctor.
ICPC is based on a biaxial structure with 17 chapters on an axis and 7 components on the other. The 17 chapters are based on the systems of the human body with 2 additional chapters, one for psychological problems and one for social problems. The 7 components are symptoms and complaints, diagnostic, screening or prevention, treatment procedure and medications, test results, administrative, others, and diagnosis or diseases. The ICPC-2 structure is divided into 17 chapters by body systems representing the localization of the problem and RTC. There are chapters for different body systems and chapters for general and unspecified issues, and chapter for social problems. The chapters for general and unspecified issues and the chapter for social problems are important to understand what happens in primary care.
For the coding structure, ICPC is alphanumeric, composed of 1 alpha that represents a chapter and 2 numeric values that represent the component. For example, FO2 is the code for red eye.
A great deal of attention is paid to the patient's symptoms and complaints in the first component of each chapter as the reason for encounter or the RFE, which is not captured by the ICD. Linkages of codes for the beginning of an encounter with the RFE to its conclusion is possible with the ICPC.
The ICPC is very compact, where in fact all ICPC codes can be summarized into a 2-page sheet as shown in the picture. You may check the file I requested you to download for the full access to the summary sheet. Notice that the summary sheet is color-coded. Those highlighted in gray are process codes, lime for symptoms, yellow for infections, light blue for neoplasms, red for injuries, blue for congenital anomalies, and violet for other diagnoses.
In order to address those that are not yet classified, in every end of each chapters, there is a ragbed rubric to cater all other concepts. So for example, S29 is considered as other skin symptoms or complaints.
Here are some of the benefits of the ICPC. First, it allows patients' health problems to be tracked over time through the recording of episodes of care and by allowing the coding of the reason for encounter and recognizable diseases or problems and interventions. Second, it reflects the frequency and distribution of health problems commonly encountered in primary care and reflects the way in which primary care providers work to solve problems. Third, it is simple and easy to use for primary care providers including doctors, nurses, and other healthcare workers, therefore increasing the likelihood of consistent and accurate coding. Fourth, it complements other classification systems such as ICD and clinical terminology systems such as SNOMED CT and READ codes. And lastly, it enables meaningful feedback to primary care. enables the exchange of information between primary and secondary care, as well as with policymakers and funders to understand what is happening in primary care, and therefore improve the provision of care. Let's have a simple exercise to fully understand ICPC. Pause this video and using the summary sheet you downloaded before the session, identify the codes for reason for encounter, problems, process for the management done to the patient in the scenario given below. Note all these codes and press resume when you're done. In the given scenario, Jane's reason for encounter is because of dizziness and headache, coded as N17 and N01 respectively. The problems are hypertension, which is K86, marital problems, which is Z12, and losing her job, which is Z06. The doctor ordered for routine urine examination, K35, ECG examinations, K42, referral to social worker, Z68, and other processes like investigating the dizziness, which is N45, and prescriptions, which is Z68.
In summary, ICPC is a classification which reflects the distribution and content of aspects of primary care. It was designed as an epidemiological tool to classify data about the three important elements of the healthcare encounter. In essence, reason for encounter, diagnosis of problem, and the process of care. ICPC was designed for the collection and analysis of patient data and clinical activity in the domains of general or family practice and primary care. This collection and analysis can occur at the level of an individual patient for clinical care, at the practice level for recall, clinical audit and activity analysis, and at the regional, state, and national level for health services, research, and statistics. It can be used to classify terminologies and other classifications in electronic health records to facilitate decision support and patient safety systems. That's all for my lecture, International Classification in Primary Care. If you have any questions or comments, feel free to tweet using the hashtag or comment in the comment section below.